Hello everyone. This presentation accounts for two lectures that will discuss selected chemotherapy for the treatment of hematological malignancies such as leukemia and lymphoma. We're not going to get into details into the subtypes of different leukemias because you cover that in pathology. However, just keep in mind as you go through these presentations that leukemia has so many different types. It can be either acute or chronic, and based on the progenitor cells, it can either be lymphoid or myelogenic. But it's important to note here that the average 5-year survival rate of all types of leukemia is around 57%, meaning that 57% of patients who are treated for leukemia survive for 5 years post-treatment, which is a very good rate in terms of treatment of cancer. Of course, this number reflects survival rate of all types of leukemia, but certain subtypes of leukemia, like for example, chronic myelogenous leukemia, is now considered a curable disease with a very high survival rate. So this relatively high survival rate of leukemia is definitely because we have improved better therapies to treat this type of blood malignancies. Note here that there is a very important difference between the treatment of leukemia and other types of cancer, in that with solid malignancies such as breast cancer, lung cancer, or colon cancer, the mainstay of treatment is surgery, right? Because with those solid malignancies, you will have a malignant mass growing at a defined area in the body that can be resected surgically, especially if cancer was at an early stage. With leukemia, the cancer cells, the leukemic cells, circulate in the blood, they proliferate in the bone marrow. So basically, there's no malignant mass defined in a certain tissue that you can resect. This means that the mainstay of treatment of leukemia is through using chemotherapy. And in fact, the early chemotherapeutic agents that have been developed and used for the treatment of cancer were first tried in patients with leukemia. That was the main goal of developing chemotherapy. Now, of course, we have different types of chemotherapy used for the treatment of leukemia, and they are mostly used in combination, a combination of drugs, which is a general rule of how anti-cancer drugs are used. But these drugs should follow a strict protocol. Okay, so for the treatment of leukemia, these anti-cancer drugs are given into 3 different stages called induction, consolidation, and maintenance therapy. So let's talk about each of these steps. The first step is to give a combination of 4 or 5 chemotherapeutic agents to destroy as much leukemic cells as possible in order to achieve a state of remission or a disease-free state. Okay, you want to kill the majority, if not all, leukemic cells that you can. This step is called induction, and it is the first step for the treatment of leukemia. It usually involves aggressive and high-dose administration of these chemotherapeutic drugs. And it is effective in most of the cases. For example, 95% of children who have acute lymphoblastic leukemia will enter a remission state within around a month after the induction chemotherapy has been given. Okay, so this is a very effective stage for the treatment of leukemia. However, it is not enough. Usually, induction therapy is followed within like 3 to 4 weeks after induction is done. It is followed by consolidation therapy. Okay, consolidation therapy is used to further reduce the number of whatever leukemic cells are left in plasma to make sure that you achieved full eradication of these cells. And that will also prevent whatever remaining leukemic cells from developing resistance to chemotherapy. Because with induction therapy, if you kill 99% of leukemic cells, the 1% remaining has been exposed to chemotherapy, and there is a chance that those 1% will be resistant to the therapy. That's why you have to hit it again with consolidation therapy. After the patient has achieved a remission state following induction and consolidation therapy, the patient will be maintained on pulse chemotherapy treatment over the next 3 or 4 years, given at cycles. They're not given over the entire year. No, it's maintenance therapy is given at a certain point during the first 3 to 4 years. And the goal of that is to prevent recurrence, because at any point of therapy, there might be some cancer cells that are still present in the body, and they might grow again, and the cancer will recur one more time. And that's why we need maintenance. That also involves giving those patients chemotherapy to prevent any leftover cancer cells from recurring again. Now, one problem that faces the treatment of leukemia is that leukemic cells can also cross the blood-brain barrier and spread through the central nervous system. Unfortunately, the majority of chemotherapeutic agents cannot cross the blood-brain barrier. And that is why patients who have leukemic cells spread to their central nervous system will require direct administration of these drugs into the CNS through the intrathecal route. And in many protocols, even if those cells have not crossed the blood-brain barrier and they're not found in the brain, most protocols recommend that patients receive central nervous system prophylaxis, okay, with, of course, chemotherapy. Remember from general pharmacology that we said that the better understanding of cancer and cancer processes and how cancer develops is the key to develop effective chemotherapy. The majority of the conventional or classical chemotherapeutic agents are considered cytotoxic. So they basically eliminate and kill rapidly proliferating cells, including leukemic cells. And these drugs are widely used until this moment. We still use them for induction and maintenance, and we will discuss several examples on them in this presentation. But also keep in mind that cancer pharmacology is developing towards using more targeted therapy, drugs that don't just destroy any proliferating cell, but drugs that can target certain selective processes found only in cancer cells. And we have lots of options available for the treatment of cancer and leukemia. And we will discuss some of these targeted therapies in this presentation as well. The first class of conventional cytotoxic therapy that we will discuss in this presentation are antimetabolites. So antimetabolites, as the name indicates, are drugs that interfere with several metabolic processes within the cell. These metabolic processes are usually related to DNA and RNA synthesis. Because interfering with DNA and RNA synthesis will definitely harm cancer cells, these drugs have been used for a long time for the treatment of different kinds of cancer. Now, methotrexate is a very important example on antimetabolites, and we have discussed this drug in general pharmacology, so I will just go through it very quickly. But you should keep in mind that methotrexate is one of the most important drugs used for the treatment of leukemia. In fact, methotrexate was probably one of the first drugs to show efficacy against the treatment of acute lymphoblastic leukemia in children. Methotrexate is a folate analog, and as you know, it interferes or inhibits the function of the mammalian dihydrofolate reductase, the enzyme responsible for activating folic acid into its reduced form, tetrahydrofolic acid. And tetrahydrofolic acid or tetrahydrofolate is a very important mediator involved in several reactions leading to the synthesis of nucleotides that are very important for DNA synthesis. Because methotrexate interferes with metabolic processes that lead to DNA synthesis, it is considered a cell cycle specific drug, mostly inhibiting the growth of cancer cells in the S phase. Remember also that we've discussed the drug 6-mercaptopurine as one of the drugs used for immunosuppression. Okay, mercaptopurine is a purine analog. It's a nucleoside analog that is used for maintenance immunosuppression. And if you remember, because of the structural similarity between 6-mercaptopurine and several nucleotides, it can be mistakenly inserted into the growing DNA chain as cancer cells or as proliferating cells in general are synthesizing their DNA, and then it can stop the progression of DNA polymerase or the synthesis of a new DNA strand. And that's how it interferes with further DNA synthesis and stops the growth of leukemic cells. 6-mercaptopurine is also used as part of the maintenance therapy for the treatment of acute lymphoblastic leukemia. So these two drugs, methotrexate and 6-mercaptopurine, have been discussed before, and we will further focus on other examples of antimetabolites. The first drug that we will discuss here is a drug called Cytarabine. Another name for this drug is cytosine arabinoside, and as the name indicates, this drug is structurally very similar to the nucleic-based cytidine. If you look at the structures of these two molecules, you will see that cytarabine has only an additional hydroxyl group that is different from the structure of deoxycytidine. Remember that in DNA we use nucleic bases C, G, A, and T, and we use them in the deoxy form, right? So cytarabine is definitely reduced in the deoxy form, and it's very similar to deoxycytidine. This means that because of this structural similarity to the normal natural nucleic bases that the body uses to synthesize DNA, cytarabine can be mistaken for these nucleotides, meaning that when the DNA polymerase is synthesizing DNA, is elongating a newly formed DNA strand, it will also incorporate cytarabine instead of the normal deoxycytidine nucleotides. This results in inhibition, first of all, of pyrimidine metabolism, because also cytarabine can interfere with the enzymes that are responsible for cytidine metabolism and other pyrimidines. It will definitely inhibit DNA polymerase from further elongating the newly formed DNA chain. And that results in what we call premature chain elongation termination, meaning that as the newly formed DNA synthesis is being elongated, it will suddenly stop. Remember also that for these nucleic bases to be incorporated in the newly formed DNA, they're not just in the deoxy form, they also have to be phosphorylated, right? They have to be in the nucleotide form, meaning that they should be either as, GTP, CTP, etc. They have to have 3-phosphate groups added to them. So cytarabine does not have any phosphate groups. That means it won't be active and it won't exert its anti-cancer effect unless it is phosphorylated. And for that, it will definitely use the same enzyme that phosphorylates deoxycytidine, which is the enzyme called deoxycytidine kinase. So this drug has to be activated or has to go through the same process that the normal nucleic bases go through in the cell. So if you look at this diagram, after cytarabine has been given, it is transported into the cytoplasm through the same transporters that allow the entry of pyrimidines into the cell. And as it goes inside, as we said, it has to be phosphorylated, and that is catalyzed by the enzyme deoxycytidine kinase. Okay, so it has to be converted into cytarabine triphosphate. The normal would be deoxycytidine triphosphate, but the drug will form deoxycytarabine triphosphate. Okay, so this molecule, since it's very, very similar to the normal deoxycytidine triphosphate, will be incorporated into the growing newly synthesized chain. However, the DNA polymerase, once it starts putting or inserting this drug into the newly formed DNA, it will be inhibited, it will stop, chain elongation will be terminated, and DNA synthesis will be inhibited, and that will result in growth arrest of cancer cells and probably can also progress to cell death or apoptosis of the cancer cell. So, do you think that the way that cytarabine exerts its anti-cancer function would be cell cycle specific? Think about that. Would cytarabine be effective orally? The answer to that question is mostly no, because since it's very similar to these normal nucleic bases, it will probably be metabolized heavily if it was given orally through first pass metabolism and even in the gut, and it won't be effective. That's why this drug is mostly administered intravenously. Now, cytarabine can be used for the treatment of many different types of leukemia, including acute myelogenous leukemia and acute lymphoblastic leukemia. It can also be used for CNS prophylaxis against leukemia. It can be used in cases of leukemic recurrence, and etc. There are multiple uses of this drug for the treatment of leukemia. And similar to any other cytotoxic chemotherapy, since cytarabine does not only interfere with DNA synthesis in leukemic or in cancer cells, it can also affect the growth and proliferation of normal cells in the body as well. That's why it can harm, for example, gut mucosa cell and can be associated with like diarrhea. It can cause nausea and vomiting, such as any other cytotoxic chemotherapy agent. Of course, it will result in suppression of the bone marrow because the bone marrow is the site where most or all blood components are synthesized. It's rapidly proliferating tissue in the body. So all those cells, even the normal ones, not just the leukemic cells, will be susceptible to cytarabine toxicity. And that will result in myelosuppression. Cytarabine can also result in liver damage and in neurotoxicity as well. The next drug that is in this category is called L-Asparaginase. So let's take a look on how the drug L-Asparaginase work. Remember that tumor cells, including leukemic cells, are very rapidly proliferating cells. This means that they have a very high and active metabolism, including very high and active protein synthesis. One of the most important amino acids that are required for leukemic cells protein synthesis is the amino acid asparagine. So asparagine can be obtained through either high-rich protein diet, or it can be synthesized in normal cells through the de novo amino acid synthesis pathways. In leukemic cells, there are two important things to know. One, that their requirement for asparagine is very high. It's higher than normal cells because they are rapidly proliferating and synthesize proteins more frequently. Second is that they have defective or abnormal de novo pathways for the synthesis of asparagine, usually due to the lack of the enzyme asparagine synthase. This means that leukemic cells will entirely depend, almost entirely, not completely, they will depend on dietary intake of this amino acid. So can we take advantage of that? Of course we can, because we can deprive or reduce the supply of asparagine to tumor cells. Of course, that doesn't mean that the patient will stop eating protein-rich diet, but we can take advantage of drugs to prevent asparagine delivery to tumor cells. One of these ways that we can interfere with asparagine metabolism in tumor cells is by taking advantage of a bacterial enzyme called L-Asparaginase. Okay, so this enzyme can be extracted from E. coli, and we can develop it into a drug that is used for the treatment of cancer. Asparaginase metabolizes the amino acid asparagine. Okay, it breaks it down into aspartic acid or aspartate and ammonia. This means that before asparagine is taken up by tumor cells and be involved in protein synthesis, L-asparaginase will break down asparagine molecules and depletes asparagine in tumor cells or in leukemic cells. This results in the inhibition of protein synthesis in the leukemic cells and leads to cell cycle arrest in the G1 phase of the cell cycle. If asparagine's dose was high enough, it will convert this growth arrest in G1 phase into apoptosis or cell death of leukemic cells. Okay, now we are done with antimetabolites. Let's move on to discuss another class of cytotoxic chemotherapy used for the treatment of leukemia. This class is called antibiotics, and I know that this might be confusing, but these drugs were originally developed to be used as antibiotics, but we found that they have a potent anti-cancer activity. Thus, these drugs are not used as antibiotics. They are used as anti-cancer agents, but we still call them antibiotic chemotherapy. These drugs involve a very important family of anti-cancer drugs called anthracyclines, and this involves drugs such as doxorubicin, daunorubicin, idarubicin, and epirubicin. You can notice here that these drugs that belong to the anthracycline group have very similar structure. This is doxorubicin, for example. This is daunorubicin. They're very similar structurally. There are just very few differences in their structure, if you can notice here, between doxorubicin and daunorubicin. However, despite this slight differences in structure, these drugs have wide different uses. For example, while daunorubicin and idarubicin are mainly used for the treatment of leukemia, doxorubicin is used for the treatment of leukemia as well as many other solid tumors. such as, for example, breast cancer. Doxorubicin is one of the frequently used drugs for the treatment of breast cancer. Remember also that doxorubicin has another very famous name called adriamycin. Can you notice that the name of this drug is very similar to many of the antibiotics that you know? Adriamycin is very similar to like clindamycin, erythromycin, etc. This just gives you an idea that this drug was first um, developed to be an antibiotic, but it turned out to be a very strong anti-cancer cytotoxic drug. So let's take a look at how these anthracyclines exert their anti-cancer effect. Okay, so these are not anti-metabolites. They have a different way of interfering with cancer growth. So doxorubicin, for example, has many different mechanisms of action. First of all, doxorubicin can result or cause peroxidation reactions in many different cell components, such as lipids, carbohydrates, and others. So it will peroxidize lipid membranes in the cells. It will peroxidize DNA in the cell, and that will result in the generation of free radicals, highly toxic compounds, especially if they were derived from oxygen. You probably know them, reactive oxygen species. So they increase the development of reactive oxygen species inside cancer cells, and that definitely results in damage of cancer cells' DNA and protein. It's a very lethal event. Uh, Doxorubicin can also result in what we call DNA intercalation. This means that the drug molecule will be incorporated into certain parts of the DNA molecule. Mainly they have a specific binding site in the DNA molecule. And this intercalation reaction, or the strict binding of the drug to the DNA molecule, will prevent DNA unwinding, which will interfere, of course, with DNA synthesis and RNA synthesis. Because if you want to synthesize DNA, you have to unwind the molecule, right? So that the DNA polymerase can create a new chain or a new strand. So intercalation of DNA with doxorubicin will block DNA synthesis by blocking the unwinding of the DNA molecule. Because of its strong oxidizing effects, doxorubicin and the other anthracyclines can also damage or oxidize purines and pyrimidines that are required for DNA synthesis. And the last mechanism of action of anthracyclines is that they also have topoisomerase 2 inhibition activity. Remember, in general pharmacology, that we said that topoisomerases 1 and 2, both these drugs, both these enzymes are important for relieving DNA supercoiling, right? Remember that we said that DNA can supercoil after it undergoes a cycle of DNA synthesis, and you will need enzymes such as topoisomerases to relieve the supercoil and get back the DNA molecule in its normal shape. So the drug doxorubicin can also bind and inactivate the enzyme topoisomerase 2 that is responsible for relaxing DNA molecule after supercoiling, and that will result in several breaks in the DNA molecule. We call them DNA double-stranded breaks. Okay, so they will generate cuts in the DNA molecule. It will be cut like that. And this DNA breaks or fragmentation are very lethal, and they can immediately induce apoptosis in cancer cells. So as you can see here, there are several mechanisms of action of how anthracyclines can damage cancer cells. Just to summarize, they can increase the generation of free radicals. that destroy cancer cells as well. They can cause DNA intercalation, and they inhibit the enzyme topoisomerase 2, which results in abnormal unwinding of the DNA molecule and causes DNA double-stranded breaks. Now, these drugs are administered intravenously. You will notice that they have a unique color. For example, doxorubicin has a very unique bright red color. It's given intravenously, and that sometimes can result in even the discoloration of the veins when this drug is administered to patients. These drugs do not penetrate the blood-brain barrier, and that's why they cannot get to the leukemic cells that have already spread to the central nervous system. Anthracyclines undergo hepatic metabolism and excreted through bile. So they have a pretty basic pharmacokinetic profile. They are very important for the use of for the treatment of leukemia. Remember when we said that for induction treatment, we usually use a combination of 4 or 5 drugs. Most of the time, one of those drugs is an anthracycline, whether daunorubicin or idarubicin. So they are a major component of leukemia treatment. But as I mentioned, doxorubicin can also be used for the treatment of solid cancer, such as breast cancer, for example. Daunorubicin and idarubicin are mostly used for the treatment of blood malignancies. Of course, these drugs have the same adverse effect profile of most cytotoxic cancer therapy. So they can cause nausea and vomiting and diarrhea. They can result in bone marrow suppression. They can cause alopecia or hair loss, etc., the same side effects of cytotoxic chemotherapy, because they will also interfere with DNA synthesis and function and will damage rapidly proliferating cells. But in addition to that, doxorubicin has a unique adverse effects. It's a very important problem, actually, in that doxorubicin can result in cardiac damage or cardiac toxicity. That's why many patients remember that leukemia or ALL is more frequent in the pediatric age group. And if doxorubicin was used for the treatment of a child of 12 years old, for example, even if leukemia is cured, years down the road after therapy has been stopped, those patients are susceptible for developing cardiac disease or heart disease, because doxorubicin can directly damage the heart. Okay, so far we discussed antimetabolites, drugs that interfere with several metabolic processes of cancer cells, including purine, pyrimidine synthesis, and DNA synthesis. We've discussed antibiotics or anthracyclines, and we understand now how they work by generating reactive oxygen species and inhibit topoisomerase 2. Now we'll move to another category of cytotoxic chemotherapy, and we call those alkylating agents. So as the name indicates, alkylating agents simply alkylate the DNA. So what does that mean? These drugs add an alkyl group to the nucleotides of the DNA molecule. These alkyl groups are added in a very strong covalent bonds to the nucleotides in the DNA molecule. Usually they tend to bind to the guanosine nucleotides in DNA. They mostly bind to the guanosine nucleotide. So what does that binding do? Now, the binding results in a very lethal cross-links. So if you have two adjacent, like this is a sequence of DNA, for example, right? This is a random sequence. If these alkylating agents add an alkyl group to one of these nucleotides, mostly would be a guanosine nucleotide. This alkyl group can also bind to an adjacent um, guanosine nucleotide, and that results in a cross-link between these two. This will prevent DNA polymerase from initiating DNA synthesis. It will be just like a roadblock against its progression. We call that, if it happens in the same strand, in a single strand of DNA, we call it intra-strand linking, meaning that the linking happened within the same strand. Now, what happens if the linking happened between the two DNA strands that make up the DNA molecule? So let's see, this is another sequence of DNA, just a random sequence, just to give you an example. And then the alkylating agent will add an alkyl group through covalent bonding on one of those G nucleotides. This can result in linking between the two sister strands, and that results in cross-linking between two opposing nucleotides, and we call that inter-strand cross-linking. Okay, because it's between two sister chromatids. So these alkylating agents, just to summarize, they add alkyl groups that covalently binds to certain nucleotides in the DNA molecule, causing both intra and inter-strand cross-linking. So this cross-linking not only prevents DNA polymerases from working and synthesizing DNA, these are also considered very toxic, and they can induce apoptosis. And that will, of course, result in the death of cancer cells. And that's why, because this event can happen whether the DNA is being synthesized or not, these drugs can just go hit the DNA molecule directly. They don't require it to be in active synthesis mode. These drugs are not cell cycle specific, and they can also affect resting cells. They're just very potent DNA damaging agents. A very important example on alkylating agents is a drug called cyclophosphamide, which is also very important for the treatment of leukemia. Cyclophosphamide is a mustard-related agent. It is definitely very similar or derived from mustard gas compounds. Those were biological weapons used in World War II, and they were also found to have a very strong anti-cancer activity. But this should give you an idea how cyclophosphamide is very toxic. And this drug is actually one of the earliest drugs as well to be used for the treatment of leukemia. As I mentioned, it results in the alkylation of DNA, resulting in severe DNA damage that leads to apoptosis and cell death of cancer cells. That's why cyclophosphamide can be used as a single agent, is a very strong drug, but in most cases, as we mentioned, it is used in combination with other anti-cancer drugs for the treatment of leukemia. Cyclophosphamide is the most commonly used alkylating agent. So we definitely understand the mechanism of action of cyclophosphamide. It's an alkylating agent, but it's also a prodrug, meaning that cyclophosphamide itself is not active. So what happens after cyclophosphamide is administered? It has to be metabolized by the CYP450 hepatic system into hydroxyl metabolites. So basically, cyclophosphamide undergoes hydroxylation in the liver, and those intermediate metabolites are then converted into two important compounds. The first is called phosphoramide mustard, and the second is called acrolein. So the active alkylating agent is phosphoramide mustard. Acrolein does not have an alkylating agent, meaning that it doesn't have an anti-cancer effect. So if cyclophosphamide will be effective against cancer, it has to undergo hepatic metabolism into the active alkylating agent phosphoramide mustard. Understanding this step is very important to understand how cyclophosphamide works. So cyclophosphamide is definitely used for the treatment of leukemias. It is also used for the treatment of other solid malignancies. You can use it for the treatment of non-Hodgkin lymphoma, as well as it is very commonly used for the treatment of breast cancer. Okay, so it's not just restricted for the use of blood malignancies. It has wide uses. In addition to the typical adverse effects of chemotherapy, including nausea and vomiting and diarrhea, alopecia, and myelosuppression, cyclophosphamide can also result in a unique adverse effect called hemorrhagic cystitis that results from direct injury of the urinary bladder and other components of the urinary tract. This first gives you an idea that cyclophosphamide and its metabolites are excreted through the kidney. So if the metabolites accumulate in the kidney and the urinary tract, such as the bladder, they will cause direct injury to these organs. Remember, cyclophosphamide is a very toxic drug. Mainly, this effect is attributed to the other metabolite of cyclophosphamide, which is acrolein. Acrolein, remember that it doesn't have an anti-cancer or an alkylating effect. However, it contributes to the adverse effects of cyclophosphamide. And in order to solve this problem, cyclophosphamide therapy should be given with adequate hydration so that you will dilute its metabolites as they are being excreted by the kidney. And you can use the agent Mensa, which neutralizes acrolein excreted in the kidney. Okay, this substance just binds to acrolein and neutralize it, and that will reduce the injury that is caused to the bladder tissue. Another adverse effect that is important for cyclophosphamide is the highly neurotoxic and probably should not be used for CNS prophylaxis against leukemia. The fourth class of anti-cancer drugs that can also be used for the treatment of leukemia are microtubule poison. And remember, in general pharmacology, we took an example on microtubule poisons, which was the drug paclitaxel or docetaxel. Just to refresh your memories, remember that during the M phase of the cell cycle, the newly synthesized chromosomes need to be separated. DNA has to be separated into the two daughter cells. And that event, which occurs in the anaphase of M phase of the cell cycle, is mediated by the contraction of the mitotic spindles. The mitotic spindles are molecules that are formed from microtubules. So as these microtubules attach to the chromosomes, then they contract, separating DNA into the two newly formed daughter cells. This means that interfering with the function of the mitotic spindle will result in failure of mitosis or proper cell division, and that results in a mitotic catastrophe that leads to apoptosis of the dividing cancer cell. Again, we took that paclitaxel interferes with microtubule function, and that's how it's an M-specific anti-cancer drug that results in apoptosis of tumor cells. There is another family of microtubule poisons that we call Vinca alkaloids. Vinca alkaloids are naturally derived semi-synthetic drugs. They are derived from the Vinca rosea plant, as you can see in the picture. These two drugs, Vincristine and Vinblastine, have very similar structures, but they have different therapeutic indications. But they are definitely one of the most frequently used anti-cancer drugs for the treatment of leukemia. So let's again take a look at their mechanism of action. We mentioned that the mitotic spindle is very important for the separation of two daughter cells during during cell division. And remember that the mitotic spindle is formed of microtubules, and each microtubule is a polymer of tubulin, right? You have different types of tubulins, alpha and beta, and these tubulins form dimers that then wrap up to form the cylinder or the microtubule that forms the mitotic spindle. Now, vincristine and vinblastine inhibit the tubulin polymerization, meaning that they inhibit the formation of microtubules. They prevent these tubulin molecules from polymerizing to form the microtubule. This means that you will directly interfere with the formation of the mitotic spindles that are responsible for the separation of DNA between the two daughter cells. So directly interfering with anaphase. And at that stage, if the cell fails to divide, it will immediately undergo apoptosis and will die. So do you think that vincristine and vinblastine would be cell cycle specific drugs, meaning that they will be active more during a certain phase of the cell cycle? Which phase would that be? Of course, vincristine and vinblastine are primary drugs for the treatment of leukemia, different types. Despite the similarities in their structures, as I mentioned before, they have different uses. For example, vincristine can be used for the treatment of Wilms tumor and Ewing's sarcoma. These are solid types of tumors. It can also be used for the treatment of lymphoma, both Hodgkin and non-Hodgkin's. Vinblastine can also be considered for the treatment of testicular cancer, in addition to it being effective for the treatment of leukemia and lymphoma. So again, the adverse effect profile of vincristine and vinblastine are the same as for other cytotoxic chemotherapy. They cause nausea, vomiting, and diarrhea. They can also cause local toxicity, especially when they are administered intravenously. So they can cause inflammation, severe inflammation of blood vessels and of veins to which they are administered to, especially if there is some extravasation of the drug outside the vessel locally. That would also result in cellulitis or inflammation of the soft tissue in the region of injection. Again, they cause alopecia. But remember that similar to paclitaxel, the microtubule poison that you already know about, that causes neurotoxicity, also vincristine and vinblastine can be associated with chemotherapy-induced peripheral neuropathy, or CIPN. So it seems that all microtubule poisons can result in this adverse effect, which is definitely dose limiting. Patients who take vincristine, vinblastine, or paclitaxel usually develop signs of peripheral neuropathy, such as paresthesia, pain, and tingling and numbness. Remember that while vincristine and vinblastine are microtubule poisons that are used for the treatment of Paclitaxel is not used for the treatment of blood malignancies. Because vincristine and vinblastine are associated with neurotoxicity, if they were administered intrathecally, they can cause severe CNS injury and death. So these are not one of the drugs that can be used for CNS prophylaxis against leukemia. So now we are done with the cytotoxic therapy, the conventional chemotherapeutics. Let me just summarize them quickly. We've discussed antimetabolites, antibiotics or anthracyclines. We've discussed alkylating agents and microtubule poisons. All of these drugs are non-selective. They destroy cancer cells as well as the normal proliferating normal cells. They are associated with similar adverse effects profiles. They mostly target DNA synthesis or cause DNA damage or interfere with chromosome separation during replication. So they basically target DNA. So now we'll move to the newer classes of drugs, targeted chemotherapy. These drugs target certain processes that are um, found in cancer cells. Thus, they are associated with the less severe adverse effect profile. They are also more effective if they were used correctly for the appropriate patients. The first class of targeted cancer therapy that changed how we treat leukemia is called tyrosine kinase inhibitors. So in order to understand the mechanism of action and the importance of tyrosine kinase inhibitors, we need to revisit some of the important processes that lead to the development of cancer. Remember that cancer is a genetic disorder, meaning that it results due to the accumulation of several mutations that happen in the DNA. Now, these DNA abnormalities or mutations can be as simple as a point mutation that leads to an amino acid substitution, or even more severe as an entire chromosomal deletions or the existence of an abnormal number of chromosomes. There is a wide range of genetic aberrations that can lead to cancer. One of those is what we call chromosomal translocation. Chromosomal translocation means that a segment normally located at a certain chromosome will be transferred into another chromosome abnormally. An example on chromosomal translocation is the Philadelphia chromosome. Of course, it's named Philadelphia chromosome because it was discovered in Philadelphia, Pennsylvania. The Philadelphia chromosome reflects a translocation where a segment of chromosome 9 is translocated into chromosome 22, and at the same time, a segment of chromosome 22 is translocated reciprocally into chromosome 9. So the resultant hybrid chromosome that results from this translocation is named the Philadelphia chromosome. So why is this a problem? It is a problem because this translocation moves the sequence of a protein called ABL from chromosome 9 and puts it in an area on chromosome 22 very close to another protein called BCR, or breakpoint cluster region. Now, ABL is a known oncogene. When ABL is translocated to chromosome 22 to form the Philadelphia chromosome, because of its close proximity to BCR, both these genes will be transcribed at the same time. The product of ABL-BCR transcription is a fusion protein. Again, I will repeat this one more time. Because the translocation puts ABL sequence, the gene sequence for ABL, very close to BCR, they both will result, of course, when they are transcribed, they will produce proteins. But because they are now close together, this will be considered as one sequence. And the protein that is synthesized when these two genes are transcribed is a fusion protein. And this fusion protein will have the characteristics of the ABL protein produced from the ABL gene. Now, the ABL protein is a tyrosine kinase, meaning that it's an enzyme that phosphorylates tyrosine residues on any protein found in the cell. You remember that phosphorylation reactions, meaning putting a phospho group or phosphate group on a protein, will most likely result in its activation. This means that ABL will result in the activation of many signaling pathways inside the cells. These signaling pathways are most likely to be involved in growth and proliferation. Now, the problem is that when the fusion protein BCR-ABL is produced, this will retain the same function of ABL, which is the tyrosine kinase function. However, because ABL is attached now to BCR, it will have a constant action, meaning that it will result in the continuous phosphorylation and activation of growth-related pathways. Why is that a problem? Because the constant uncontrolled stimulation of growth signaling pathways will eventually lead to cancer, because cancer is characterized by uncontrolled growth. This is one of the mechanisms that happen during the development of leukemia. Because we understand how that problem happened due to the translocation between chromosome 9 and 22 and the resulting formation of the always active tyrosine kinase, which is the fusion protein BCR-ABL, we were able to design a drug that selectively inhibits the BCR-ABL fusion tyrosine kinase. And that drug is called Imatinib. Imatinib is famous for its trade name Gleevec, and it was the first targeted cancer therapy that we have developed. And the development of Imatinib was just basically because we understood one of the processes that lead to leukemia. Note here that this translocation, the Philadelphia chromosome 9 to 22, happens only in leukemic cells. It was one of the causes why they became leukemic. This means that Imatinib will interfere with this abnormal fusion protein only in leukemic cells, meaning it's more targeting of cancer cells. If Imatinib was successful in blocking the activity of BCR-ABL fusion protein, it basically just binds to the active site and prevents its ability to phosphorylate other proteins. This will inhibit further proliferation of leukemic cells. Remember that these cancer cells highly depend on the action of BCR-ABL fusion protein. So when you inhibit its function, the tumor cells will go into a growth arrest and probably will undergo apoptosis or cell death. The good news is that with Imatinib therapy at only 400 milligrams per day, and note here that Imatinib is given orally, patients diagnosed with Philadelphia chromosome positive chronic myelogenous leukemia will have a response of 70% to the treatment, and the estimated survival rate of the first 3 years is 94%. Those 94% patients will often be considered cured of CML. So Imatinib was one of the first examples to show that we can cure cancer completely using a single agent or a single drug. But remember always that in order for Imatinib to be functional, the leukemia type, or the patient who has leukemia, must have a Philadelphia chromosome abnormality in their leukemic cells. Because if they didn't have that 9 to 22 translocation, then they won't be that abnormal fusion protein, which is the target for Imatinib. So Imatinib won't work on anything. It only targets that abnormal fusion protein. So in Philadelphia chromosome negative leukemias, Imatinib is usually not indicated. So what are the therapeutic uses of Imatinib? As I mentioned, it is approved for the treatment of chronic myeloid leukemia, and you know that chronic myeloid leukemia is associated with the Philadelphia chromosome or the 9 to 22 translocation. It can also be used in adults who have relapsed or refractory Philadelphia chromosome positive acute lymphoblastic leukemia, in addition to other types of leukemias where Philadelphia chromosome is positive. Imatinib, of course, despite having less severe side effects than cytotoxic chemotherapy, it can also cause myelosuppression, fluid retention. The most important adverse effects of Imatinib is that it can be associated with the risk for congestive heart failure. After the development of Imatinib and its magical effects in the treatment of certain types of leukemia, there were so many other tyrosine kinase inhibitors that were developed. Some of these are highly used for the treatment of leukemia and many other cancers, like for example, for leukemia and other blood malignancies, drugs such as dasatinib and nilotinib. These are more frequently used than imatinib. They're even more effective. Dasatinib, for example, is indicated for Philadelphia chromosome positive acute lymphoblastic leukemia that shows resistance or intolerance to the conventional cancer therapy. It is also indicated for newly diagnosed Philadelphia chromosome positive chronic myelogenous leukemia in chronic phase, especially if there was a previous resistance to prior imatinib therapy. For example, if you're treating chronic myelogenous leukemia, CML, with imatinib, but there was resistance and the patient is not responding, you can switch to dasatinib. Of course, dasatinib is very potent. It's an orally active drug, and it inhibits the BCR-ABL fusion protein, in addition to many other tyrosine kinases that can also drive the growth of cancer. So it's a wide spectrum tyrosine kinase inhibitor. But it's a more potent inhibitor of the ABL-BCR fusion protein than imatinib. It's a stronger drug than imatinib. Patients who had newly diagnosed Philadelphia chromosome acute lymphoblastic leukemia who have received dasatinib in one study as an induction therapy where those patients, around 53% of them, have achieved complete remission from leukemia, indicating that dasatinib is a very useful drug for the treatment of leukemia. Let's now move on and discussing some other concepts that are important for the treatment of leukemia and other blood malignancies. Of course, we have several other drugs, compounds that have developed in the last few years that have improved the way that we treat leukemia. So most of these agents are targeted therapies. They are designed to target certain processes of cancer. But before we get into them, I want to remind you that corticosteroids are one of the most important drugs for the treatment of leukemia as well. And drugs such as prednisolone or dexamethasone, these are indicated for the induction, consolidation, and maintenance of leukemia. They are part of any treatment regimen of leukemia, and they have been used for the treatment of leukemia in combination with cancer chemotherapy for a long time. In addition to that, since we now understand how leukemia happens better, we have better treatments. The obvious example was Imatinib, which targets a very clear abnormality that happens only in leukemic cells. So what else can we do? Remember that when we discussed immunosuppressants, one of the drugs that was also indicated for the treatment of leukemia was a drug called rituximab. And remember that rituximab targets the receptor CD20, which is present on B lymphocytes. So if a patient has been diagnosed with a chronic lymphocytic leukemia, and his or her leukemic cells were positive for CD20, then you can use rituximab in that patient because it will result in apoptosis and death of the CD20 positive leukemic cells. The target of rituximab is CD20, so that it will only work on CD20 expressing cells. If the patient was diagnosed with a form of leukemia that was negative for CD20, the cells do not express the receptor CD20, then rituximab will not work. This applies to similar other drugs that either target CD19 or CD3. These receptors are present on the T cells, and also applies to many other targeted therapies that only their activity depend only on the presence of certain receptors or molecular targets of leukemic cells. This means that it is very important, if you want to treat leukemia, is that to run a profile or an analysis to know what are the molecular characteristics of leukemia in that patient. Is the patient positive for Philadelphia chromosome? Is the patient positive for CD20? Is the patient positive for CD3, and so on and so forth. And based on that, you can choose the best drug combination to treat the patient. Remember that because of the use of chemotherapy that result in myelosuppression, patients with leukemia receiving cancer chemotherapy will be at risk for acquiring infections and opportunistic infections. That's why part of the treatment of leukemia will include also antibiotics or antimicrobials and antifungals. Note also that myelosuppression will result in a significant reduction in the number of normal circulating red and white blood cells. That's why these patients might have anemia that will need correction with drugs like erythropoietin, or they will have neutropenia that will require correction with colony stimulating drugs such as filgrastim and pegfilgrastim. So let's take an example of chemotherapy combinations used for the treatment of leukemia. Note here that we have different regimens, different combinations of these drugs. For example, for the treatment of acute lymphoblastic leukemia, one of the commonly used combinations is called hyper-CVAD, and this includes stands for hyperfractionated cyclophosphamide, so it includes cyclophosphamide. V means vincristine, A means idrimycin or doxorubicin, and D means dexamethasone, okay, which is a corticosteroid. As I said, corticosteroid is a part of any treatment regimen for leukemia. So the hyper-CVAD used for induction Treatment of acute lymphoblastic leukemia consists of this combination of chemotherapeutic agents. CalGB 8811 regimen, this is another regimen or another combination of chemotherapy used in certain centers. This contains doxorubicin, vincristine, prednisone, L-Asparaginase, and cyclophosphamide. Okay, so it's a combination of different drugs of different mechanisms of action. And the reason, I will just remind you, why do we use combination of treatment for cancer is that one, you will be attacking the cancer using different drugs of different mechanisms of action, so different ways of killing cancer cells. This will definitely reduce the risk of the cancer cells to develop resistance. This will also allow you to use these drugs at a lower concentration, meaning that you will reduce their toxicity. Of course, the toxicity of each individual drug. For non-Hodgkin lymphoma, we have a very famous, very commonly used chemotherapy combination called CHOP, C-H-O-P, which contains cyclophosphamide, doxorubicin, vincristine, and the corticosteroid prednisone. So just to finish this presentation, I will just give you an example of how a newly diagnosed patient with acute lymphoblastic leukemia will be treated. So as we mentioned, the first part of therapy will be induction therapy that is aimed to kill the majority of leukemic cells and achieve a status of remission. And this usually happens by a combination of drugs, 4 or 5, depending one of those regimens that I have just discussed with you, such as the hyper-CVAD regimen. After 3 or 4 weeks of therapy, the patient will receive consolidation chemotherapy and will continue to receive maintenance chemotherapy for a few years. Now, remember that you always have to run certain markers, and that will help you to select which targeted therapies you want to use. For example, if the patient had positive Philadelphia chromosome leukemic cells, then you can use a tyrosine kinase inhibitor such as Imatinib or Dasatinib. If the patient had positive CD20 B lymphocytes, then you can probably use rituximab. So you need to understand the mechanism of action of each drug to know where to use it. Remember that many patients receive intrathecal chemotherapy for CNS prophylaxis against the spread of leukemia, but remember which drugs are very neurotoxic and cannot be used for that purpose. Also keep in mind that while chemotherapy is the mainstay of treatment of leukemia, some patients will require stem cell transplantation or bone marrow transplantation. All patients with leukemia will require supportive care throughout the treatment process, including providing blood products, sometimes blood transfusion, drugs that will enhance RBC and white blood cell production, that will correct the anemia, or will prevent the development of opportunistic infections. The final note is that the treatment of leukemia is not just by one drug or not just by one chemotherapy agent. It is a combinational therapy of anti-cancer drugs, anti-anemia drugs, antibiotics, growth factors, and etc. Thank you all for listening, and if you have any questions, please don't hesitate to get in touch with me.